We've talked about cellular regulation, we've talked about gas exchange, we've talked about airways, artificial, we've talked about venous access, and now we're talking about perfusion. So uh, one of our exemplars, endocarditis, that will be some vegetation on the endocardium produced by fibrin and platelet deposits on infection sites. Causes the valve to not open and close, which primarily decreases cardiac output, damaging different chambers of the heart. So as the heart is not able to open or close, then it's just basically fighting itself and pushing that blood uh, either against a closed valve or the valve is open and it's not able to get that full filling before the heart beats again and pushes all the blood back out. The vegetation can also break free, causing emboli. If the emboli occurs on the right side, that will go to the brain, kidneys, limbs, liver, and spleen. If it occurs on the left side, it'll be going to the lungs. Some causes of endocarditis would be bacteria, fungi, viruses, and once you develop this endocarditis, you can develop a murmur, which will be able to be auscultated. Damaged valves may need replacement. Rheumatic heart disease is from rheumatic fever or strep, and that's really all you need to know on endocarditis. It's just the vegetation on the endocardium because of an infection. Pericarditis is a bigger one. It is the inflammation of the pericardial sac. Fluid fills that pericardial space, and so the heart cannot fill up. Uh, just like with the lungs and the hemothorax, if you have two bags in each other and you fill one of them up, the outside one up, then that inside bag there's less space because it has to displace all that other fluid to be able to fill that up. So you're going to see some decreased preload and also decreased cardiac output when you have this pericarditis because that heart it's having some pericardial friction rub where the inflammation in the sac around the heart is causing the heart to just rub up against it. And anytime you rub up against anything, you don't wear socks, and the heel of your shoe is rubbing your right at your Achilles tendon, then you're going to get raw there. And so that's where the sharp chest pain will come from in acute cases. You can actually auscultate this, and they may develop some JVD from the blood backup. So one worse thing that can happen with this would be the pericardial effusion, which is a medical emergency, and that is the fluid building quickly around the heart in the pericardium, and you will also see the narrowing blood pressures. So the systolic and the diastolic will be very close together. So you see here I got an example 120 over 110. Those are very close together within 10 units. Millimeters of mercury, if you will, I guess. Some diagnostics you can run to diagnose pericarditis: echocardiogram, CT, MRI. Treatment would be treat the underlying cause. You can actually give NSAIDs first, and then corticosteroids, and then antibiotics once you figure out exactly what's happening here, or an antifungal. And then you also want to give them a proton pump inhibitor because of the NSAID use. So nursing interventions you can take: administer the NSAIDs with food to decrease that peptic ulcer risk or gastric difficulties or problems. You also want to keep the head of the bed elevated. That way it'll take some pressure off of them and allow them to breathe and you also want to put a cardiac monitor on them. They should be continuously cardiac monitored, but that's not always the case. You just want to have that cardiac monitoring in place. Auscultate and assess the heart and lung sounds. That's a big one. Again, just like everything else, we're establishing that baseline, getting that assessment done, so that way we can go from there and build off what we have. Hemodynamic monitoring, labs, like always, and like always, DVT prophylaxis. There's several options for surgery to fix it. They can do a partial pericardiectomy, which is they take out some of the pericardium, or they can also do a pericardiocentesis, where they aspirate some fluid from the pericardial space, which will increase the preload because you're taking that fluid off the heart. It's not pushing down on the heart, or it's not, pushing on the heart. Some risk for that would be infection, because we are piercing that space and introducing a new object. Bleeding, perforation of the pericardium. You want to assess for effectiveness, so they should have increased cardiac output and increased preload. Next is myocarditis. That is when the myocardium becomes weakened. That can be from viruses, bacteria, radiation, fungi, or just can be idiopathic. Contractility is greatly reduced with myocarditis, and blood backs up, causing pulmonary edema and pulmonary hypertension. So some assessment findings you'll see with this would be S3 and S4 heart sounds. Then you'll have muffled S1 heart sounds on auscultation. You may notice a gallop. The patient may be tachypnic. They may show some signs of JVD because, again, the blood's backing up. Hepatomegaly, arrhythmias, cool extremities, again, poor circulation, weak peripheral pulses, and poor capillary refill. Treatment for this would be treat the cause, administer oxygen, put the patient on bed rest. When you're giving digoxin, hold if the heart rate's less than 60. You want to monitor those dig levels for digoxin toxicity. Assess for hypokalemia before your administration of digoxin. You can also give them an antiarrhythmic as well as an anticoagulant such as Coumadin, and also your ACE inhibitors, which end in pril, lisinopril, any of those. Nursing interventions, you want to keep the patient on bed rest and also place the patient on cardiac monitoring and then monitor those hemodynamics, those labs. Obtain your daily weights. Any cardiac anything, you're going to obtain those daily weights. Assess for lower extremity edema, and then when you assess for it, if it's present, then you want to assess if it's pitting or non-pitting. And then also we can give them small frequent meals, so that way we're not pushing that stomach up into the diaphragm and just condensing all that, because they want to eat 2 Big Macs and a 20-piece nugget or something. Cardiomyopathy. This occurs when the vessels are dilated and the heart becomes hypertrophic. Dilated is a contractility problem. Same signs and symptoms of myocarditis, because it causes cardiomyopathy. So myocarditis can cause cardiomyopathy, and then cardiomyopathy can also have a hypertrophic aspect to it, which is when the muscle wall in the heart becomes thickened. And so now, if it was like that and now it's this thick, then there's decreased room because the wall's thicker in the heart. So there's decreased room for the blood to fill, so that means decreased cardiac output. They may have dyspnea on exertion or exhibit some signs of fatigue. Treatment would be beta blockers, calcium channel blockers, and the beta blockers will decrease ventricular contractility, which will make them a little bit more flexible, I guess. They may undergo surgery to remove excess muscle, so they may thin down that musculature inside the heart. You want to be careful when you give them nitrates and digoxin when the blood pressure and heart rate are already kind of soft. And then they may get a cardioverter or a defib implanted as well. Now just moving on to some hemodynamics. I'm just going to go over some general numbers, terms, procedures, I guess. Preload. CVP has to do with preload, and you want to be between 2 and 8 millimeters of mercury in the superior vena cava. High causes would be left-sided heart failure, pulmonary hypertension, fluid volume overload. So just think if you have all this backing up, especially if you're auscultating pulmonary edema or your patient has fluid volume overload, they're edematous, then you'll probably see some increased CVP. Low causes, the exact opposite. Fluid volume deficit. You want to give fluid, assess for flash pulmonary edema because you are giving them more volume. And then POP is also preload. And so that you want to be between 4 and 12 millimeters of mercury, and that'll be measured the left ventricle diastolic. Afterload, systemic vascular resistance is a part of that. You want to be between 800 and 1200. Low would be dilated vessels, fluid volume deficit, shock, sepsis. And then high would be increase in pressors, fluid volume overload, hypertension. Contractility is another aspect of the heart, and then cardiac output. With cardiac output, we'll basically just be measuring it with MAP, the mean arterial pressure. You want that to be between 70 and 100. We can do 65, but if it's less than that, they're probably not getting perfused adequately. So you can calculate MAP by doing systolic blood pressure plus diastolic blood pressure times 2, and then divided by 3. And this is just some procedures for a code. If somebody were to code, you want to start CPR, and then you'll administer epinephrine 1 milligram every 3 to 5 minutes. You should also have someone designated to record, just one person. And then every 2 minutes, you'll perform a pulse check, assess pulse for about 10 seconds, and then go back to CPR. During the code, you want to assess for the cause, so that way if it was something that we can have an impact on, we can get that addressed. And sometimes it's not. You want to check the pulse for a shockable rhythm, and just keep giving your epi and then checking your pulse every 2 minutes. When it comes to defibrillation, Cardiovert is between 50 and 100 joules. It's a low power. It's synchronized. You can synchronize the patient if they are perfusing. Remember, R on T waves are bad. A normal defib is 120 to 200 joules. It can be biphasic. It's a normal defib, and then it can also be monophasic, which is 360 joules. After defib, restart CPR if needed, and also ACLS certified RNs can run a code. Let's see, and now we just have arterial and ventricular pacing. So arterial, if they are arterial paced, you'll see a spike before the P wave, and if they are ventricular paced, you'll see a spike after the P wave but before the QRS. And then if they are AV paced, then it'll be both. So remember, ART before P, ventricular before QRS, and AVs both. And that should cover all of perfusion.